Okay, good evening, everyone. Welcome
to tonight's web speech. But before we have a talk that we brought you all here, I wanted to say something about Gilles. And he is unaware I'm doing this because he doesn't know why I'm up here. So I'd ask Marie-Laure to come forward as well. The enrichment programs are events that take place through the entire year. And each year we rotate someone who creates an intellectual vision that becomes a reality through the events that take place the spring, the winter, the spring, and the fall. And for this year, the vision behind the remarkable set of events that have taken place has been Gilles Lubinot. And I wanted to thank him and recognize him because it has really been remarkable what he has done. Now, this is just something because this is the ultimate and closing event of this year's enrichment programs, and we will also be recognizing Gilles in his division in a more formal mechanism. But I just wanted to interrupt him and introduce our introducer to say thank you very much for everything you've done on behalf of the university.
Thank you. Thank you so much.
And we have more that we will represent and give to you at the time of the formal recognition, but Marie-Laure has a small set of things to give you now.
Thank you very much. Thank you. Thank you so much. Thank you. Thank you. Thank you very much, and thanks to everyone. My pleasure. So, tonight, this is going to be the last event for the enrichment program for 2017. I don't want to give a long introduction for Andrew because he will introduce himself. He will be much better than this. But what I want to say, just two things. First thing is that tonight's keynote is very important because you will see somebody who really use technology in design to really change daily life of people, and this is really important. And the second thing I wanted to say is the title of this keynote is the best one that you could imagine to close our enrichment program because its title is Changing the Way the World See, and this is exactly what we wanted to show for this enrichment. So Andrew, please come. Thank you.
Thank you. Hello, everyone. I'm going to start with a small story about two ladies who I met whilst I was living in Kenya. This was in a rural clinic in a place in the Great Rift Valley, and these two ladies were best friends. They'd known each other for many, many years and were living in neighboring villages. And over the years, they shared their family lives, their challenges, their successes. But 10 years prior to this photo, they stopped seeing each other, literally, because both of them had gone blind. And this picture was taken moments before we called their name as part of a group of 23 to take them on a bus 3 hours away to the nearest hospital. They didn't actually realize they were sat next to each other. And it was only when we called their names that they realized they were together. And from that moment on, they held on to each other all the way to the hospital 3 hours away. The sad thing is their story isn't really very unique. They're 2 of 36 million people worldwide who are blind, and the majority of people worldwide who are blind don't need to be. 4 in every 5 people who are blind from a condition for which there is already a cure or a preventative treatment. And it's not just the individual who's blind that's affected, it's the entire community. It's very typical to see a scene like this. So the date of this was a midweek Wednesday clinic, and if you look carefully, there are 2 old men with white sticks, both with young children next to them. It's very typical that when somebody goes blind, someone else is taken out of the community to be their eyes for them. That child, therefore, no longer gets the opportunity to go to school and becomes the escort for that person. And if you look at where people are blind worldwide, this is a map that I created that changes the shape of the Earth to show you where most blindness exists. So you can see sub-Saharan Africa and Asia are very swollen, and the Americas and Europe is very thin. But if you look at where eye doctors are based, it's the exact opposite. They're mostly in Europe and the Americas. And nowhere is there a greater disparity between those who need treatment and those who can provide it than in sub-Saharan Africa. And just to give you a sense of the numbers, for every eye surgeon who's working in Kenya, there's 100 working in the UK. There's over 3,600 in the UK compared to 86 in the whole of Kenya for a similar sized population. In the capital city, Nairobi, 50% of those eye surgeons are based. So you have 43 working in Nairobi, which serves 8% of the population. And as you go out to the more remote rural areas, you can have a single surgeon responsible for a population of 3 to 5 million people. And it was because of this that in 2011, I left my role as an eye surgeon in the UK, and my wife and I moved out to Kenya, packing all our belongings and lots of eye equipment, and went out with our 1-year-old son to start a new life. Whilst we were there, I was working with the London School of Hygiene and Tropical Medicine to do a big piece of research. The research required me to establish 100 temporary eye clinics, and those eye clinics were spread across the Great Rift Valley so that we could find people and understand why people were going blind and what might be done about it. Often the locations were fairly beautiful, but incredibly difficult to reach. So if you look at this clinic, which was run in a school, there's actually no road access to it. And where this picture was taken from was where we had to stop our 2 vans, unload $150,000 worth of eye equipment and 15 people, and carry the equipment all the way down into the clinic, which took an hour and a half just to be able to get to the clinic. And when there was road access, we spent a lot of time doing this. Out of the 100 clinics that we went to, 70 had very poor or no road access. It's no wonder that it was difficult for patients to come and receive treatment. When we would get to the clinic, we had the latest state-of-the-art eye equipment, the kind of stuff you'd expect in the best hospitals in the world, and we were able to deliver very comprehensive examinations and tests. The problem was, in almost 80 of the 100 clinics, there wasn't a stable power supply, so we had to run everything from a petrol-powered generator. The thing that initially excited me about the work there was that when we would turn up, there would be often 200 to 300 people waiting for us because they'd heard we were coming. But actually, this became more and more of a problem because I realized that I could spend every day, all day, seeing as many people as possible, and I would hardly be seeing anyone of those who actually needed care. So although it felt like I was making a difference, I realized that actually I was making even less of a difference than I thought, because the number of people in that queue who had conditions of blindness that were totally unnecessary was huge. And whatever we did was not going to be enough to reach the hundreds of thousands of people in that area that needed support. And I was struck one day when I was in one of these clinics, and I was going to, and this was one of the typical clinics, it had no road access, it had no electricity, and it had no clean running water. And I went to go and use the bathroom, which was a pit latrine. And as I went to go in, I heard somebody's mobile phone going off inside the pit latrine. So obviously, being a doctor, I was most concerned about the hygiene, but actually the thought that really struck me was, I'm in the middle of a place with no roads, no electricity, no water, but there's good mobile signal. And this is true across sub-Saharan Africa, where more than 80% of people have access to a mobile device, but only 50% have access to clean running water and sanitation services. I found this to be such a ridiculous statistic, yet equally an opportunity. And others have seen this opportunity. Some of you will be familiar with M-Pesa, which means mobile money. M-Pesa is a way of transferring money via text message and is now responsible for around 1/4 of Kenya's GDP. People who never had a bank account but now have a mobile device effectively are able to have an identity in a bank account through it. And times have changed in a very short space. I'm not sure if any of you are familiar with this, but this is a 5 megabyte hard drive in 1968. 1 year later, this computer was responsible for putting a man on the moon. That computer is 300 times less powerful than the first iPhone that came out in 2007. 8 years ago, an Android device came out that was more powerful than that first iPhone that cost only $10. So technology has moved at a pace that is hard to believe, and access to connectivity has moved at an unbelievable pace. So these two huge issues, one of huge need, but also huge potential in terms of how we're now connected. And it was because of those that we developed Peak. The idea initially was to look at each one of the comprehensive eye tests we were doing in the clinic and find a new way of doing it, replacing it with a mobile method that could be not necessarily operated by a specialist, but by anybody. And the first was a way of measuring vision, and I just want to do a quick vision test on everyone in the room just to check that your eyes are healthy. So if you're wearing glasses, could you just take them off for a moment? Now, Up on the screen here is a big letter E, which is pointing that way. So I want you to all point that way. There you go. Now, as the E changes shape and size, I want you to be able to point it, and I'm going to look out for any of you who can't see, and then we'll get you up on stage to do a more comprehensive examination. Let's see how we're doing. There we go. All right, you're getting the principle now, so it's getting smaller. Yeah, a few people dropping off now. Okay, so that's the principle of the test that we built on the smartphone. So we didn't want a test that was dependent on the English language, because we wanted to test vision, not literacy. And so we used that same principle, but did it on a smartphone. But the key thing here was the examiner just needs to respond to the gesture. So if you're pointing up, I swipe up. If you point to that way, I point that way, without actually needing to know if you're giving me the right or the wrong answer. The intelligence is in the phone, which is telling me whether you're getting it right or wrong, and it's progressing it accordingly. So as you can see here, I swipe in the way that is being asked. If the patient looks and gives the wrong answer, I still swipe that way, and the algorithm records it. If they shake their head so they can't see, you shake the device, it records that you can't see. And then it automatically ends the test and provides the result. We then started putting this in the hands of non-doctors and non-nurses. So these were school leavers, people in the community, to go and use this in different scenarios to see how effective it was. And one of the things that we started noticing was when we compared the results to the main chart that was the gold standard, around 2/3 of the results were perfect, but 1/3 were nonsense. They didn't make any sense, and we couldn't work out why. So we started to tap into every part of the phone's technology to see if there was any more information we could gather. And one thing we used was the lux meter. So all of your devices, all of your smartphones have this sensor, which is primarily used to change screen brightness from inside to outside to save battery and optimize the viewing of the screen. But we were able to read how bright the room was every time we did a vision test to see if there was any correlation between the result and its accuracy. And what we were able to show was that above a certain reading, 900, that was always consistent with when the result became incomprehensible. So we thought, well, the theory must be that if you're testing in bright light, you're getting screen reflections, which make it difficult to do the test. So we encouraged the team to make sure they always tested indoors and in the shade. And they said, yes, Dr. Andrew, we'll do that, no problem. They went and tested another few hundred patients, and when the data came back and I analyzed it, the results were exactly the same. So the next time I went with them door to door, and I realized that the issue was I was asking them to do a 3-meter test, but most people's houses weren't big enough to let someone stand 3 meters away. So they ended up having to do the test outside. And it was a typical example of trying to make the environment fit the test as opposed to the test fit the environment. So we then redesigned the algorithm so that it would work at 2 meters rather than 3 meters, at which point we had 95% of people able to be tested indoors. And then we needed a way to make sure that we were the right distance from the patient. So we tried all sorts of things, including the other front-facing camera and using Pythagoras and doing some basic calculations of triangles to make sure we were always the right distance. That didn't work very well. We asked people to hold up a credit card or an ID card because it was a consistent size, but people didn't like you taking a picture of their credit card or ID card, so that didn't work very well either. We even tried using echo, so a pulse of sound to make sure we were the right distance. That was not very effective. But then we came across a genius solution which made everything work, and that was a piece of string cut to the right length. So often the solution is not technological. The other thing we discovered is there are limitations to what you can do within an app. And this is a case in study in that this lady, having her vision tested, was being told the answers by her daughter. So it's quite common for the community to want to support one another, which is nice in principle, but was no longer giving us the result of the person we were testing. And you can't control for that in an app, so there was a certain element of training and support that had to be delivered alongside it. And so we ran a study, once we'd got the app to a point where we felt this was effective, where we compared it to, excuse me, let me just have some water, where we compared it to the gold standard test, the one on the top right. And we tested people both at home and again in the clinic the following day to look for repeatability. So if I test your vision one day and I test it the next, I expect the result to be the same. We also did the same with what is known as a Snellen chart, which is the standard vision test that's done in most physicians' rooms or opticians. And what we found was our test was as accurate as the gold standard, it was more repeatable than the clinical standard, and it was much quicker than both. And we published the data back in 2015. So the vision test tells us that somebody can't see, but not why they can't see. To understand why someone can't see, there's various things you need to do, including being able to see inside the eye. Now, this is an image of the retina. The retina has more information about the human body than any other part of you. So on the far right there is the optic nerve, which is a direct extension of the brain. So you can see a huge amount about the brain's health by looking at that. Then these are blood vessels, arteries, and veins that are coming out and into it. So you can see things that include diabetes, high blood pressure. You can see things like malaria, HIV. All of them have signs on the back of the eye. So it's possible to get a huge amount of information about somebody's health by looking in the retina. The issue is, to look at the retina usually requires what was known in medical school as a guessing stick, where the examiner has to get very intimately close to do the assessment, and they have to know what they're seeing as they see it to be able to interpret it, which means the test can only be done by people with specialist training, which we've shown are very few in low and middle income countries. The alternative is to have a nice big desktop camera, like the one we took out to the field, but these can cost upwards of $50,000. They get fantastic images, but they're not designed to move around. They're designed to be static in a hospital. So I started looking at what were the other methods that I'd been taught throughout my training as an eye surgeon, which you could use for examining the retina. One technique was known as indirect ophthalmoscopy, where you wear a special hat with a light source, and you hold a lens, which is a bit like a magnifying lens, and you shine the light through the magnifier, and it creates an image on that lens, which you can look at. And I realized that the principles of how phones work, so the iPhone 4 was the first one that came out, which had a camera and a flash that you could use simultaneously. And I realized that the principle was the same, that if I held it like that, you would start to be able to get images of the back of the eye. Here you can see a man who has lots of yellow at the back of the eye. That's scarring from laser treatment for his diabetes. So I thought this was a good solution, but the reality was the technique and the subtleties of it required the same skills as wearing the hat stand, which meant it was still limited to doctors who were used to doing the technique, so it wasn't so effective to go much wider. The next technique I started to work on was using what was the best smartphone at the time in terms of camera, which was the Nokia N8, so this is going back around 6 years now. And I retrofitted this optical device onto it and changed some of the lenses. I managed to rope in a precision engineer to help me cut all the different pieces. And at this point, I thought I was really onto something. So here you can see somebody getting an examination. You can even see pulsation of the blood vessel at the nerve. Those yellow dots there are signs of macular degeneration. So you're even able to age the patient. So I was able to really get a great view, and I thought at this point I'd solved the problem. And I remember my wife being extremely excited. She's a children's doctor, saying this was going to change everything, and she'd had every single one of the devices I'd made over the years tried on her. So she was pleased I'd finally got there. And then took it to Kenya to test with the team, and probably within around 2 minutes of using it, realized it wasn't going to work. The learning curve was too steep. It still required you to be able to use the attachment, the ophthalmoscope to it. The pressures and the additional skills required to make this usable for everyone were too big. So although it worked in my hands, it still didn't work. And that was a real disappointment, and I felt at that point needed to start again. And it was at that time, a few months later, that I met somebody working in Scotland, an engineer who at the time was at the forefront of 3D printing, when 3D printing was a completely new thing. And when I met him, he'd just 3D printed his own 3D printer. So it gives you an idea of the kind of thinking this guy had. So I said to him, look, I've spent 6 months designing this, and it needs to be completely redesigned, but the time it takes me to do other iterations is just too long. So he scanned what I'd made and 3D printed it within 24 hours, which was this design here, which was both brilliant and really frustrating that he was able to do in 24 hours what I could do in 6 months. But then we started working together to say, well, we need to condense this down to something that's so small that it could fit on any smartphone, that it could be so low cost, but also simple enough that anyone could use it. It needs to be as easy as taking a picture on a phone. And so we came up with multiple designs, but within the space of around 2 months, we got to a point where this low-cost, simple version, designed specifically at that time for the Samsung S3, so it gives you an idea of how long ago this was used. And here's my long-suffering wife having yet another retinal examination. But you can see the quality was really good. So at this point, we started putting it in the hands of nurses and school leavers in Kenya to see if they could use it. And we found that typically within 45 seconds, people were able to get an image of the retina with no prior training. So we really felt at this point we were actually onto something. So in the same way with the vision test, we started to run a trial within the larger study that I was doing. And so we had school leavers using a smartphone and this clip-on adapter, and ophthalmic technicians using a desktop camera, all taking images of the same patient. Those images were sent to London, to Moorfields Eye Hospital, where they were independently graded, and the images were compared. And you can see this is on the same patient. The top image is on the phone, the bottom is on the desktop camera. And we published that data back in 2015. When that happened, we suddenly got huge amounts of interest. The BBC covered it. It was lots of excitement and interest, people saying they want to buy one. But I realized that we had no way of giving it to anyone. You know, you can't 3D print this at scale. And it was a medical device, which meant it has to go through a process which is not suitable for 3D printing. And that was really hard because we realized there was something people wanted, but we had no way to get it to them. We had no money to manufacture it. We had some money which we'd won from a prize through Mazda and TED, but we knew that we needed a total of at least £200,000 if we were going to manufacture it. At that time, a group in the US approached us and offered us a 7-figure investment to help us take it forward. And this was one of my first lessons in business. So I at that point, wasn't thinking about running a business. I was just still focused on the fact that there was these queues of patients. And my concern was if we'd taken that money, we would have gone down a route that was about this product, but it was never actually about the product. But I wasn't able to distill my thoughts on that at that time, so I wanted to buy time, and also wanted to know, was there really a market for this? So what we decided to do was run a crowdfunding campaign through Indiegogo, where we basically asked people to buy one before we made it. That way we could get sufficient income to build the production pipeline, but without having to give away part of an organization that didn't yet exist. And fortunately, we were able to raise all the money, and we estimated it'd take us a year from getting the money to be able to build it. So rather than 365 days, in the end, we ended up having to start all over again because the design we had was for one specific phone, wasn't meeting medical standards, and we basically had to start the whole thing again, which we only discovered a year into the process. So it took a total of a painful 881 days to actually get it to the point where it was actually a product that we could take to market. And I remember every one of those days, but this is what the final product looks like. So we ended up designing a universal clip that could go on any smartphone because we had to stay ahead of the fact that smartphones are constantly changing. If we designed it for one phone, by the time we got it to market, it would be redundant. We also started working on software that enhances the image quality. So here it uses a panorama function, so you can see it starts building an image of the retina as you go in real time, so that where we're having to make compromises in terms of having low-cost hardware, we can use software to get a comparable quality image. But as I mentioned, this was never actually about making apps and making hardware. It wasn't the point. The point was there were these queues of patients who needed treatment, who were blind and visually impaired and didn't need to be. And I was working with a colleague of mine, a brilliant ophthalmologist called Dr. Rono, and he was one of these doctors that was responsible for 3 to 5 million people on his own. And he said to me, look, I'm working in schools, I'm sending one of my best nurses from the hospital to go to the school to examine all of these children. But the problem is when they get there, although there's lots and lots of children, they only find around 5% with a problem. So that's for every class of 50 children, two out of the 50 that have a vision problem that's severely affecting their lives. But it also means 48 out of 50 don't. So that means when you're sending somebody who's already working in a very busy clinic and you're sending them to a school, they're no longer in that clinic. It isn't like there's lots of spare nurses. So their time was then spent, with the majority of it taken up on seeing children who are normal. So we thought, well, this is not a very effective use of the limited resources that are there. So what we then said, well, if the application is effective for adults, let's see if it works for children, but this time in the hands of teachers. So we did some testing with teachers, and this is an example of it being used in a school. And I remember this teacher particularly well. Here's him just doing some testing.
Show me the direction it's facing. Direction.
Now, this teacher was very interesting. One, because when I was being introduced to him, I said, you're the English teacher. And he said, no, I am a teacher of English, and I am Kenyan. So his English was better than mine. But I remember we learned lots of things by just observing what was going on in the classroom. One was that the children were drawn to it because it was on a phone and it was new. But also they were much more willing to do this test than the normal test. And the reason was, on the normal test, people can see if you're passing or failing. And no child likes to fail in front of their peers. And so they'd be very resistant to doing it in front of other people, where others could see that they weren't passing. Also, if you were wanting to trick the system, which I remember doing as a child, you could learn the chart on the way in, and when you're close enough, you could remember it. You could also remember it from one eye to the next. So there's actually quite a lot of ways of overcoming the standard test, but that's not possible to do it with this because it automates and randomizes the order in which the E's are shown. The other thing was that the teachers would always say, once they got the result, what does this mean? You know, getting a result of 618 or 2040 doesn't intuitively mean anything to someone unless you spend your time examining eyes. And we realized we need to present the result in a way that was visually understandable. So we created an algorithm that generated a blur according to the test that had just been delivered. So on half of the screen, it shows the visual world of that child immediately after the test is done. And for many of the teachers, that was a penny drop moment. They instantly understood what it was like to be that child. We hear lots of comments like, I just thought they were lazy. I thought they weren't paying attention. They didn't realize that they couldn't see. And the thing is, the child doesn't know that they can't see either, because that's the world they've always known, so they've never been able to tell you that they can't see. And because it isn't the child or the teacher that makes the decisions as to whether that child goes to get treatment, we then started carrying a little Polaroid printer that used Bluetooth, and we would create that image on a little photograph with some additional information that the child would take home and give to their parents. And that helped the parents understand the issue that the child had and why they needed to do something about it. We also then built a back-end system. That system was designed so that whenever a child didn't pass the test, it would give a prompt to the teacher asking them to put information about, including the child's name, their parent's name and local language and phone number. And as soon as they pressed save and went on to the next child, it would auto-generate an SMS that was personalized to that child's parent, sending them information to say your child has been seen on this date with this problem, and this is what they need to do. It would also send an aggregate message for data from that school to the head teacher, telling the teacher how many children in their school had been seen, how many had a problem, how many needed to be followed up. And if you look carefully on the far side of this image, there's a huge trophy on the desk. So head teachers and deans of universities are very, very competitive. So we used that to incentivize the head teachers to make sure the children in their school got treatment. And the way we did that was not by telling them how many children needed treatment or how many had been seen. We told them how many the next school had done compared to them. And that made them start sending children en masse to go and get treatment at the hospital. We also created an analytics dashboard which allowed the program manager to see all of this in real time. So every single time a vision test was being done, we knew where it had been done, who had done it, what the result was, and what the outcome had been, which meant we're able to track an entire community of people in real time, from being tested to being followed up to being treated to what the treatment was and where there were any gaps in the system. Where did people not follow up and get treatment? We could also view it geographically. So here you can see grey schools are schools that we're going to visit. Blue are ones that have been visited. The darker blue they are, the more screening that's happened. And then they start to go green as treatment has been delivered. And in our first trial of this, we ran it as a randomized controlled trial. 21,000 children were screened, and we identified 900 with visual impairment. That was done by 25 teachers in just 9 days. And what this showed us was there was potential here to take this to scale. Bear in mind that it had taken me a year and a half to see 7,000 people. We'd suddenly seen 21,000 in just 9 days. And one of the things we would do to train the whole school at once is something similar to what we just did. So I'm just going to show you some children in an assembly not too dissimilar to what we did a moment ago. Don't know if you can see the child on the far side there. So he was copying his friends like I saw some of you guys doing in the test. So the program initially all started in Kenya, but one of the unique ways in which we've tried to make this scalable is not have everything centralized where we go and set up the next program. So one of our project leaders in Kenya actually traveled to India and trained the team in India. So it wasn't the team in London training the team in India, it was the team in Kenya that trained the team in India. So we now have a similar program running in India, and we also now have deployed a large program in Botswana, which was piggybacking a vaccination program where nurses were going to schools to deliver vaccinations, and we upskilled them to be able to do vision tests in the schools. And we've just completed a district in Botswana and now have agreement from the government that we are going to screen and treat every single school child in the whole of Botswana by 2020. And it will be the first country in the world where every single school child is receiving comprehensive eye services. Because most low and middle income countries have a large and young population, that's one of the reasons that we focus on that age group. Partly because it's around a third of the population and children will live for a lifetime with the consequences of poor vision. But also, the over 50s are a very significant and important age group. Around 1/8 of the population is over 50, but they carry 80% of the burden of severe vision problems, so primarily blindness due to cataract. And so we also deploy a program similar to the principles of our school program, where people go on foot door to door with a solar-powered rucksack, so they no longer need a power supply. And when they find someone in their home, are able to locate them and identify them, and then link them through to services. And on our dashboard, similar to what you saw with schools, we're able to find people in any given location. We can search by any of the parameters that we've generated. So here, people who are blind from cataract are depicted by red pins. Every one of these people is detectable, contactable, and treatable. We're able, similar to the principle in the school system, to send bulk text messages. But we also realized quite early in this process that sending an SMS to somebody who's blind is not a very effective way of communicating with them. So we needed to make sure everyone was linked to someone in the community who could follow them up. So part of the process is to find what we call a key informant in each place who can group people together and be responsible for arranging transport and follow-up for them. So this whole process, we learned a huge amount in. And actually, the biggest bulk of it is not technology, it's about people. And so the idea of technology being scalable is true, but taking human processes and people is much more challenging. And we were very clear that we were not going to solve a problem by just releasing some apps and some gadgets. It was that whole end-to-end process that needs to work if we're actually going to change the lives of the millions of people who are unnecessarily suffering with vision loss. And so over the last 3 years, we've started to build a fabulous team, which includes someone who joined us from Google, who was previously head of Android partnerships and had built the Google Africa team. He's now head of partnerships at Peak. We have a product designer who's brought 40 different products to market. Our senior technology team comprises of someone who built the Lloyds mobile banking system. And we have a really wide range of skill sets, very few with a health or eye care background, but are really bringing different skills to the sector, from design to mobile to deals to product. And it's because of this fabulous team that we're now in a position where our software app has been released as a medical device. So the vision test is available in 154 countries. So if you're an Android user, you can download this anytime and use it for free. Our hardware, Peak Retina, shipped earlier this year, is now being used in 72 countries. But the focus of our work is not on the individual pieces, but on the whole connected system. And the reason the whole connected system is so important is that if we identify someone and they don't get treatment, we actually haven't created any impact. And so we're not interested in just doing as many tests as we can or selling as many hardware products as we can. What matters to us is that people who are blind and don't need to be are getting the opportunity to have their sight restored. And what we've realized in the process is there are barriers to access which are consistent everywhere that we've worked. And they can be summarized as A, B, C, D, E, F, G. So awareness, bad services, costs, distance, escort, fear, and gender. And I'll just explain each one briefly. So awareness is that the individual who's blind is not aware that there is treatment. They think this is how it is. I'm old, I've lost my sight, this is how it's going to be. They're not aware that there's an option for them to get their sight restored. Equally, at policy-making level, governments are not aware that there are lots of people in their population who are blind and don't need to be. So there's no imperative to change that or do anything about it. Bad services, what I mean by this is that if you find someone and they turn up for services and either the care provider is not there or they have to queue for hours, that is a bad service, and it may be enough to put them off going. So if I tell you there's a fabulous restaurant on campus and you go and book and they say, yes, come back in 6 months, you're probably not going to bother to go again. So even though they can provide good care, if the service is not good, then people don't go. The cost for many is too big. And that's not just the direct cost, but also the indirect cost. When you're living in a hand-to-mouth culture where what you grow that day is what you eat, you can't afford to not prepare food for the day. So the cost of going somewhere else is major. Also, the distances people have to travel to go and receive care is often huge, where you've seen some of the images from before, how difficult it was to get to them. You can imagine how hard it is for them to come to a service. Also, people forget about the escorts, so they plan to send a vehicle with 10 seats to bring 10 patients. But if you're blind, you can't go on your own. And most people who are blind have become very isolated and lost their dignity, and they won't be willing to travel somewhere without a companion. So you have to allocate space for that companion, both for the transport and in the hospital. Fear is a huge issue. There are all sorts of stories that go around and myths about what happens if you go for an eye operation. That is enough to put a lot of people off going for care. And gender, all of those barriers are met with higher barriers for females. So we find that around 60% of those who are unnecessarily blind are women and girls. So I'm just going to explain one or two of these in a bit more detail. So fear was one that I first came across whilst working in Sierra Leone, where we were offering treatment to patients, and they said, we know what you'll do. You're going to take my eye out and replace it with the eye of a cat. I thought, what a strange thing to say. Of course we're not going to do that. And they said, we know, we've seen what you do. And at first, myself and my colleagues were thinking, what a strange myth that's going around. But we realized that there was actually a good reason for them to say that. And although the procedure that was being done was resulting in very good vision, the cosmetic appearance of the eye afterwards was not great. And so this would be often what the eye would look like. And so the pupil, rather than being round, would be pulled. It had no effect on vision, but it did cosmetically look a bit like the eye of a cat. And we realized that it's not enough to just give a good result. There is a cosmetic result that matters as well. And this was putting people off coming. Another example of fear was, whilst living in Kenya, we would offer people free surgery and free transport. And I would hear the team talking in Kiswahili to the patient, saying, explain the procedure, and then saying, "Supasuaji." And then I would see this look of kind of fear on the patient's faces. And I would ask the team, what does that word mean, supasuaji? And they say, oh, it means operation. And I said, why do they always look so scared? And they said, I don't know. And we were trying everything. We were offering free surgery and free transport, and still half of people would say no, and they wouldn't come. And then one day, in a different context, I was walking along the high street, and there was a butcher's there, and I heard them using the same word, supasuaji. So I went and said, what do you mean when you say that word? And they said, it means to cut or to split. And so in the local language, there was not actually a word for operation. And what was being used was the word, I'm going to split your eye or cut your eye. So you can imagine if I come and I say to you, come with me, I'm going to give you free surgery, I'm going to pay for all of it, I'm going to arrange transport, and then I'm going to split or butcher your eye. I'll say, thanks, doctor, but I'll give it a miss. And it was these fundamental differences that technology doesn't solve those problems. That's only being embedded in the community and understanding what is causing the fear that has to be overcome. So we started using a new word which meant translated more closely to fix, and then lots more people started to come. Another was that people were disconnected from the care they were being provided. It was very much people coming, doing tests, saying things, leaving paper, but not engaging the patient in a way that they felt connected to the whole thing. And one of the things that I noticed in all of the houses that we went to is that people really treasured photographs. And particularly if it was a colour photograph, there was huge value. People would have photos that had been on their wall for 40 years, and this is just in a traditional clay house. But this very sweet lady had a picture that really surprised me on her wall, this was genuinely in her house, this poster of Arnold Schwarzenegger carrying an automatic machine gun. And what just struck me was how much any colour photograph is valued. So in the same way in the schools, what we did here was we started giving people a photograph. And initially we started giving people a photograph of their eye, but they didn't really want a picture of their eye. What they wanted was a picture of themselves. So we gave everyone a colour picture of themselves, which we could do there and then after we'd examined them, which would contain on it just a little QR code so that when that came to the hospital, the information was all accessible. And people felt much more engaged in the process. And this intervention alone doubled the number of people that started coming to the hospital. So what we're now doing is trying to take those processes, and those processes are not around having the answer, but it's around having the question. So everywhere we go, we have the same set of questions that we ask. And the answers are different in each place, and we learn a huge amount every time we go. We've run these programs now in Kenya, Botswana, and India, and what we're doing is harnessing that knowledge to come up with a way of productizing that process so that it can be repeated much more efficiently and in a much less demanding time manner. And so we've taken what we've learned so far, and we're now repeating that in Rwanda, starting this month. But what we don't intend to do going forward is to go and start lots of new projects in new places. Instead, what we're doing is partnering with organizations who are already working in lots of places. So we've just signed agreements with 2 international NGOs who, between them, work in 80 countries. And they've already built the relationships on the ground. They already have the teams on the ground. And our intent is to take our process and our technology and to work with them in all of the places that they're working. So it becomes a train the trainers, so they take it and they can go into multiple places, which means we can reach a lot more people. Part of our process is before we're on the ground doing any kind of training or software development, is we go with our toolkit to ask some key questions. In that population, how many people do we expect to have the problem? And we do that from research or existing studies or doing small pilot tests. And then how many care providers are there for that population? Because there's no use us finding people if there's no one who can provide treatment at the end. And we need to know that if there is treatment, we bring in people at a rate that the services can manage. Again, if you take a restaurant analogy, if I tell you there's a restaurant outside and all of you go at once for the same time, then the restaurant isn't going to be able to cope. But if we change your bookings so that you can go spread over the course of 2 days, then the service can manage it. So we want to make sure that we balance the demand with the service provision. And what that looks like is we get a sense of, can that service cope with how many people and at what rate? And if there is capacity to see more people, then that's the kind of place that makes sense for us to start working. But equally, there are places where we go where there's already a waiting list. We go and there's already a queue of people who are not being seen. So all we would do in that scenario is create a bigger queue. And if you create a bigger queue, you start to create a bad service. So in that place, it wouldn't be effective for us to go. So we're always very conscious that wherever we go, we are aware that is this a place that's going to benefit from what we're doing. And in a place where, such as that example there, where there's already a big queue, what's needed is not to create more demand for patients, but it's to build more capacity for treatment. So I'm just going to give you just a short explanation of how we're now structured as an organization to try and do this at scale. So a bit about our business model. So we are two organizations. We are the Peak Vision Foundation, which is a UK charity, and the Peak Vision Company. Now, the foundation owns the company. It's the 100% single shareholder of the company. And the company is a registered manufacturer of medical devices. So the company is making all of the apps, all of the hardware, all of the services. And to date, we've been primarily funded through grants received by the foundation and used in the company to build those services. In 2018, we'll have created and finished most of the things that we're building. And we're moving to a point next year where rather than 95% of our funding coming from grants, 70% is coming from service delivery. So now NGOs and governments are paying for the services. And this is very important to us because we want to create our sustainability and income from where we're creating the change. So we don't want to be dependent on an external source giving us the money to deliver the care on the ground. We want the care itself to be responsible for sustaining us. And that way we can always remain focused on how do we create impact, not how do we create profit. And we're on track to do that and to be a sustainable organization by 2020, at which point any profits made by the company are returned to the foundation. And the foundation can use that money to help in the scenario like the one we described here, where actually what's needed is not to bring more patients to the service, but to train more people to build more capacity. And the foundation can then provide grants to be able to build greater capacity in those populations. And that way we get a holistic overview of going in and always saying, what is the need? Not what do we have, but what is needed, and then being able to provide answers to those specific solutions. And the reason we do all of that is because of people like those two ladies who I described at the beginning. Because for many of them, they're waiting for years and years, blind unnecessarily. And it's time that changed. And this is what happened to these two ladies the day after we found them. Thank you.
Thank you very much.
Yeah, great.
Questions? Thank you for the talk. So what during your field work do you think are the common eye ailments that you come across? And the second question is like, how much do you think is genetic and malnutrition? Like between the two, how do you think what is the breakup of these ailments?
So the most common conditions that we're coming across are, in the children, it's refractive error, so the need for glasses. And in adults, it's cataract, so a clouding of the natural lens in the eye, which is an age-related change. They are not specific to a genetic profile or to malnutrition. They can certainly be accelerated in those scenarios, but if in Saudi you took away the healthcare providers, the picture would be exactly the same. So it's primarily an issue of access. So it's not that these are tropical. Many of the tropical diseases, such as river blindness and trachoma, are almost gone now. And the primary causes of poor vision are that there is a barrier to accessing services. So if you create that same picture almost anywhere in the world and take away the service providers, you end up getting the same scenario.
Thanks. You mentioned that in the eye, when you're analyzing the eye, you can also see other diseases. Are you using your technology for diagnostics of other diseases as well?
So within our systems, we focus on always providing an end-to-end solution. So we have been using it for diabetic retinopathy, so using it within a diabetes service. However, because it can be used as a standalone, other people are using it for other things, such as in accident and emergency, when people come in with headaches to look at, is there swelling of the nerve? Other people are looking at with people with high blood pressure. It's been used in studies of malaria, because malaria is detectable at the back of the eye. So there's lots of different ways it's being used independently of our systems. So in the same way, anyone could use something else to look at the back of the eye. The difference here is it's handheld, and you can separate examination from interpretation. So the biggest barrier before was you had to know what you were looking at when you were seeing it, otherwise you were effectively seeing noise. Here you can see noise, but know that you've captured it and send it to someone else who can interpret it.
We have a question from a young boy here. Yeah.
Why does laser treatment change the way your eye looks?
So there's different types of laser treatment. The pictures I showed you there was laser at the back of the eye, which is done for people with diabetes. So with diabetes, what happens is the blood vessels in the back of the eye stop working very well, and the oxygen that is there to feed the retina goes down. So as a response, the retina grows these new blood vessels to try and fix the problem. The problem is these new blood vessels are very thin and weak. It's like making bad roads. So they're actually very dangerous, and they break and bleed. So the way laser treatment at the back of the eye works is it actually kills bits of the retina so that the retina demands less oxygen. So it's a bit like doing an amputation. So you're effectively reducing the amount of retinal need for oxygen so that these blood vessels don't grow. But there's another type of laser, which is probably more familiar to lots of people, which is laser at the front of the eye, and that's done to stop needing the use of glasses or contact lenses. And so that's actually something that you can't see, but it's just changing the shape of the eyeball so that you can bring images into focus. Good question.
Thank you for your report. It was very interesting and great system to help people. My question is about the telephone. Are you planning to create some other diagnostic technique like grid of Amsler, visual field, or measurement of intraocular pressure? So are you planning to do something?
Yeah, so there are a variety of other ophthalmic tests which are of value. So we have a tablet-based visual field test that we are designing and testing at the moment, which uses gaming technology. So it uses an eye tracker. So it was designed really, I think, to squash different things on Candy Crush and things like that. But we use it to track eye movements to see if you can see something in your peripheral vision. We also have a contrast sensitivity test. So that's looking at, rather than black on white, how good is your visual system with grey. But we're focusing our tests on, when you're using it in the community, you basically need to make a binary refer or not refer decision. So we just need enough information to know, does this person need to get further in the system? So our focus is being able to do that as well as we can, rather than on providing alternatives to clinicians. Although it can be used by clinicians, what we do know is clinicians already have tools. So our focus is really on the community side.
Thank you.
Other questions?
Is it possible to see if someone's getting blind but they're not already blind, and be able to prevent it before it happens?
Yeah, really good question. So yes, it is possible. So you can by doing the vision test, you can see that somebody's vision is getting worse, but they're not yet blind. And also by looking in the eye, you can see why. So you can see it might be because the lens is starting to go cloudy, but isn't really dark yet, or because they have a problem at the back of the eye. Things like diabetes can be treated before somebody loses their sight. But if you've lost your sight, you can't get it back. So it's actually really important. So prevention in these things is really important. And the problem is, if you don't know you're losing your sight, you won't go and get an examination, which is why it's really important we go to people rather than wait for them to come when it's too late.
There is a question in the back there.
This guy's a budding eye doctor. He's got some good questions.
Okay, so thank you for the presentation. My question is, you mentioned that the business aspect, you're working towards a sustainability plan that profits from the service itself and not external factors. And how are you planning to do that?
So to date, we've been funded primarily by grants and some crowdfunding and prize money, which has basically been the equivalent of our startup capital. And although we could continue to get money from those sources, we'll do that only for the foundation side of the work, but we need the company to become sustainable in and of itself. And the way we do that is by charging for the impact that we create. So for example, with the government of Botswana, we are charging them not for the project, but for the outcome. So they don't have to take a risk on paying for a project, but they pay for the outcome, which generates the social outcomes as well as economic outcomes. So we've shown in Botswana for an $8.5 million investment, they get a $1.3 billion gain over the lifetime of those children. But they only pay for that if we create the change in those children. So it de-risks it for the payer, but it also means we can incentivize impact at the center. So we only get paid if we create the outcome. And that way we're building a model that's working.
Thank you so much.
Thank you. More questions? We have one there. Oh, it's very far away. Huh? You need to...
You might need to kick it.
Yeah.
Someone catch it in the middle.
Good. Another one.
Hey.
Okay.
Beautiful. Thank you very much. This is very impressive. At the beginning, you mentioned that people in places like Kenya have more access to phones than they do to water. But for the technology to work, there is a smartphone requirement. Do you foresee a problem with that in Kenya or other areas?
Because the recipient of care doesn't need a smartphone, it's only the person going and doing the screening. So, for example, that program where 300,000 children in Kenya are being screened requires 12 smartphones, not 300,000. So it's not a requirement that all the beneficiaries have one. As long as they have a connected device, the parents or carers can receive an SMS on a non-smartphone.
Okay.
Good evening. Thank you. Very impressive. I have a question regarding your foundation. Do you take individual donations?
We do. They're very welcome.
Okay. Because it feels like I want to go immediately and give you donations. But one of the questions I would ask is how transparent you are in terms of what goes to administrative cost and what goes to all the other costs of running the operations.
Yeah, so one of our core values is transparency. So because we're creating transparency in the health systems that we're working in, we can't do that if we're not transparent ourselves. So, we've actually just published our annual audit, which has all of our details in terms of where money's spent, who it's spent on, where it goes. And it's actually incredibly important to us as a culture of how we work, where we're not just transparent in terms of how we deal with our financials, but we're transparent in terms of where things didn't work. So where have we put time, money, resources, and then it has been ineffective so that we can learn from it. And yeah, it's core to our success that we're open with everything. So yeah, we are transparent, and where people feel that we're not, it's important that we hear about it.
More questions? So I was wondering about the health community. I mean, did you meet any resistance from the clinicians or people who are running the test to switch from the classical microscope inspection to this system, or how did they react to introducing this new technology?
Generally, we've had no major resistance. We've done adoption studies where we've, because I say you can have a test that works, but if someone doesn't want to use it, there are reasons, and we've investigated those. But what we've found is the only resistance comes when there's a misconception that this is going to take away jobs. Whereas the reality is it's going to create more work, not take away jobs. And I think as soon as people understand that this is not there to compete, but it's there to create more care, then generally we haven't had an issue with it.
And you have no problem with the people who build the microscopes because you do for $5 something that they sell 20,000?
Not really, because we're not competing in the same market. Yeah. So what they're creating doesn't get to the places that we're working. So for them, it's a place that they don't have interest in.
Yeah. Any more questions? No? So thank you again for this very, very wonderful talk. Thank you. So.